Biologic Congress for the kind invitation to be here, and they have asked me to attempt to summarize in half an hour our concepts today of treating rheumatoid arthritis. And I must admit that I've heard two wonderful presentations, so that I could theoretically shorten mine already, but I have prepared a few slides that may highlight a few additional aspects over and beyond of what has been presented up to now. Well, Professor Drosos has already addressed the pathogenesis, and we believe today that some putative antigen, foreign or autoantigen, is presented by antigen-presenting cell to a T cell, and that T cell gets activated either to a Th1 or to a Th17. That's what we believe. I will show the limitations of these thoughts in a minute. And these activated T cells then provide help for B cells, and the B cells become activated, mature to plasma cells, secrete autoantibodies which engage with their antigens to form immune complexes, activate complement, and the interferon gamma and or IL-17 secreted by the activated Th1 cells plus the immune complexes via Fc receptors or complement receptors turn the macrophages into highly cytokine-producing cells that secrete TNF and interleukin-6. We know here in red that interleukin-1 is not an ideal target, which lead to inflammation and obviously also to the destruction that is so characteristic of rheumatoid arthritis, which, thank God, we see less and less today with better approaches to treatment. With all these pathways and all these cells and molecules and all these thoughts about pathogenetic aspects and all the experimental data we have from animal models, we would tend to think that we should have cured rheumatoid arthritis already by today. However, when we look at the map of effective and ineffective therapeutic approaches, looking at therapeutic success and failure, we know that TNF is a great target, IL-6 is a great target, B-cell is a great target, co-stimulation molecules appear to be a target, JAK inhibitors appear to be a target, but IL-17 and IL-1, I mentioned IL-1 already, appear to be relatively weak targets, and IL-12, which induces Th1 cells, and IL-23, which induces Th17 cells, have failed to show efficacy, a paper that will very soon be published in the Annals of the Rheumatic Diseases on guselkumab and ustekinumab. So, with many of these drugs, even though some of the potential targets have failed, but with many of these drugs available, we need today to address of how to best use these agents. And one of the pivotal insights of the last 10 or 12 years is that remission in rheumatoid arthritis truly conveys the best outcome, and it is particularly stringent remission that conveys the best outcome in terms of clinical aspects, in terms of structural aspects, halts progression of joint damage, in terms of comorbidities. Cardiovascular risk gets reduced to normality and even better. And an alternative target for patients that cannot reach remission, the second best target is low disease activity. Obviously, all of these, and that has already been mentioned in the previous presentation, needs to be sustained over time. However, in order to address how to best approach the therapy to our patients, we need to understand when a therapy is not working and when we may need to switch a treatment, or when is the time to say, well, this treatment is working and we should continue it. And if we look at an optimization exercise that we published just shortly, we can see that if we look at simplified and clinical disease activity index improvement of 80% at 3 months, we can predict low disease activity for 70% of the patients at 6 months. So at 3 months, we know exactly, or very close to exactly, of whether a patient will be close to reaching the target. And with 80% improvement, there is even a 30% chance of reaching at the target of stringent remission, SDI-CDI remission. With 50%, we have a good 30% chance of reaching the target of low disease activity at 6 months. So at 3 months, we can already predict whether to continue a therapy if there is at least 50% improvement, or change the treatment. And by 6 months, the target should be reached. I've mentioned the simplified and the clinical disease activity index. We've done this exercise also for the DAS28. However, the DAS28, which was a fantastic tool when it was developed and remission wasn't in reach, the DAS28 remission has an issue with residual activity. And when I speak about approaches to treating rheumatoid arthritis, I obviously have to include also the approaches to assessing disease activity, because optimal therapy is obviously associated with optimal management and optimal assessment of the disease. This is a study from Utrecht which looked at the contribution of the individual variables, swollen joints, tender joints, ESR, and global health, to the DAS28 score. And as you can see, swollen joint counts contribute only half as much as tender joint counts by virtue of the weighting, 0.28 versus 0.56 to the square root. So if you have 28 swollen joints, they contribute 1.5 to the DAS28 score. Bear in mind, the DAS28 remission is 2.6, so it is almost only half, 28 swollen joints. And how much is 1.5 for tender joints? Only 7. So 7 tender joints weigh like 28 swollen joints. When we come to the ESR, the upper normal limit of ESR is 20 millimeters, and that contributes already 2 on the scale of the DAS28, with the steepest part of the curve being below that. I will being in the normal range. I will come back to that in a minute. But let me show you what the issue is and why we have to critically address how we evaluate disease activity these days. I've mentioned abatacept and rituximab, and these drugs have also been mentioned before. Now, we all know that these agents do not target cytokines. They target cell-cell interactions or a B cell. And as you can clearly see here, the DAS28 remission rate is somewhat lower than the ACR70 rate. And that's logical. Remission should be less frequent than a 70% improvement, and obviously less frequent than a 50% improvement. However, when IL-6 is targeted, such as by tocilizumab, you can clearly see here in this study, in the option trial of methotrexate insufficient responders, that DAS28 remission is more frequent than ACR70. And in the RADIATE trial on TNF inhibitor insufficient responders, DAS28 remission is not only twice as high as ACR70, but even numerically higher than the 50% improvement. And that is just not logical. So it suggests a remission situation and thus leads to undertreatment of patients, meaning progression of damage and continuation of a bad physical function and quality of life. Obviously, tocilizumab targets a cytokine, and as I indicated before, the acute phase reactants are highly weighted in the DAS28 formula. Now, even when you target TNF, this is the COMET trial, then you can clearly see, again, a cytokine, that the DAS28 remission is more frequent than ACR70 and almost as frequent as an ACR50. So a remission rate that is as frequent or more frequent than 50% improvement, can that be called remission? Now, what is the explanation for this? The explanation comes from an analysis of patients on tocilizumab in DAS28 remission who were divided into clinical disease activity index remission, clinical disease activity index low disease activity, or CDAI moderate disease activity. And bear in mind, close to 20% of these patients were in CDAI moderate disease activity. Let us look at tender joints. In remission, CDAI remission, in DAS28 remission, you have close to 0 tender joints. Low disease activity 1, moderate disease activity a little bit over 2. We can live with 2 tender joints in remission. However, when we look at swollen joint counts, we see that the mean, and I repeat, the mean of the swollen joint counts is 6 in patients with CDAI moderate disease activity. That means that some patients go to 10 and 12 joints, and that cannot be regarded compatible with remission. The evaluator global follows the tender joint counts. The patient global and patient pain follow almost the swollen joint count. But how can it be that these things occur, that we have a patient global assessment of 3.5 and patient pain assessment of 3.5 in remission, and 6 swollen joints in a remission state that actually is consistent more with a moderate disease activity? This is simply by the change of ESR within the normal range, because in CDAI remission, DAS28 remission, you are at 6 millimeters, and I'm speaking of 6 millimeters, whereas in CDAI moderate disease activity and DAS28 remission, you are at 2 millimeters. So a change of 4 millimeters of the ESR allows one to have a swollen joint count of 6. Again, an issue with the weighting of the acute phase reactants. This is the hack, and the hack confirms what I've been saying: less than 0.5 in remission by CDAI, close to 1 in moderate disease activity by CDAI, despite the fact that both these groups are in DAS28 remission. Earlier this week, we have published a paper looking at tofacitinib. We all use DAS28 ESR interchangeably with DAS28 CRP. Now, with tofacitinib, and in the United States and in other places, in Europe it is not yet licensed, the licensed dose is 5 milligrams BID. DAS28 ESR gives you at 6 months 8% remissions, which is close to what you see with SDAI and CDAI. However, DAS28 CRP gives you 27% remissions, 3.5 times as many. So these two are not interchangeable. And what is the reason for that? The reason for that is that tofacitinib and JAK inhibitors in general have different effects on CRP. They normalize essentially CRP, and little effect on ESR, because they do not affect anemia, and therefore the ESR still remains somewhat elevated. And this discrepancy allows a discrepancy between DAS28 CRP and DAS28 ESR. But let me move to another issue that is frequently addressed these days, and that is the follow-up of patients, not by clinical means, but by sonographic means. Many people believe that sonography should be the way to go, and that patients should not, and we've heard in the previous talk about reduction of therapy in remission, extension of intervals, dose reduction, and many people claim that if you have power Doppler signals, if you have sonographic active disease, you shouldn't do that or even increase therapy. Can that be held up? This is data from Glasgow, recently published in the Annals. Here our colleagues used the TASER trial to address clinical low disease activity in a treat-to-target approach, or sonographic remission, power Doppler of 1 or less. Both groups had the same escalation. If these did not reach low disease activity, the next step was made. If these did not reach the power Doppler of 1 or less, the next step was taken. Now, what did the authors expect? The authors obviously expected that the sonographic arm would have a better outcome, but that did not happen. The primary endpoint was the change in DAS-44, no difference between the groups, no difference in the HAC, no difference in the CRP. And equally importantly, no difference in X-rays. The X-ray change was good in both arms. And even more surprising, because they used sonographic remission in one arm, no difference in MRI, neither MRI synovitis nor osteitis nor erosions. There was only one significant difference, and that was in the use of biologics. 3 times as many and significant difference. A very similar trial was recently published in the British Medical Journal from Norway, Tore Kvien's group. In the Arctic trial, they also compared clinical versus sonographic remission, and they were even more strict because they didn't look at DAS-28 low disease activity, but DAS remission plus no swollen joint and plus no X-ray progression. And there was no significant difference in the primary endpoint in the ultrasound versus the conventional tight control approach. And if you look at the disease activity score, the lines were almost superimposable. And when you look at ACR-Euler Boolean remission, the lines were almost superimposable, crisscross all over. The only thing that was significantly different again was the biological therapy. So the authors concluded that the use of ultrasound information for targeting therapy in early RA does not lead to improved patient outcomes, but to overtreatment and inefficient use of healthcare resources. So forget ultrasound for follow-up. Use ultrasound for differential diagnosis. So now let us address management. We've heard a lot about management in the previous 2 presentations, and I would like to discuss with you the updated RA management recommendations, which are not yet published. I've presented them at the EULAR Congress. They're currently in review, and they are based on 3 systematic literature researches on synthetic DMARDs, including conventional synthetic and targeted synthetic DMARDs, and also glucocorticoids, on biological DMARDs and on safety. The EULAR recommendations already since the beginning, since 2010, adhere to a treatment to target approach, the target being the 2011 published ACR-Euler remission criteria, or at least low disease activity by any score. And importantly, in contrast to ACR, EULAR does not distinguish between early and established RA, but rather between treatment phases, because we did not find evidence that DMARD naive patients early in the disease course have a different outcome when being treated with any type of therapy compared with, sorry for that, compared with patients who have long-standing disease. So this is the algorithm, and I'll go by the algorithm. Oops, it changes by itself. Do you know why it changes by itself without me pressing anything? Okay, okay. I don't press anything, and it changes by itself. It's okay. I mean, let's stay here. EULAR suggests, and repeatedly so, to start with methotrexate at an appropriate dose, 20 to 30 milligrams, 25 milligrams ideally, and to combine methotrexate with short-term glucocorticoids. Short-term glucocorticoids, why is that the combination and the starting regimen that EULAR suggests to be used? There are many papers showing that if you use even just very low doses of glucocorticoids with methotrexate or other DMARDs, you have a very good outcome. And the last of these papers came from Leeds. Our colleagues in Leeds, from Paul Emery's group, believing that infliximab plus methotrexate would be better, than methotrexate plus glucocorticoids, randomized the patients to a conventional regimen of infliximab plus methotrexate compared with methotrexate plus a single shot, one bolus of IV glucocorticoids, 250 milligrams once. The rest was placebo whenever infliximab was added. And the primary endpoint in the double-blind period was at 6 months. And at this primary endpoint, there was no difference in low disease activity. If anything, there was a numerical advantage for the glucocorticoid group. And also at 1 year or at 1.5 years, there was no significant difference. And also with respect to X-rays, there was no significant difference. The best trial in arm 3 and 4 showed very similar data. Wassenberg and Svensson showed similar data, at least in the efficacy of methotrexate compared with methotrexate plus glucocorticoids. So this is why EULAR recommends to start with methotrexate plus glucocorticoids and not with a biologic. We heard in the previous talk data on combination therapy. EULAR does not believe anymore that combination therapy of conventional synthetic DMARDs is any better than monotherapy. There are several trials that show that, but one of the latest trials is the Carrera trial, and what the Carrera trial did was it used methotrexate at a relatively low dose, 15 milligrams, prednisone at a relatively high dose, 30 milligrams, but tapered rapidly, and compared this with combination therapy with higher doses of prednisone, or same prednisone dose, but again, combination therapy. And as you can see here, primary endpoint at 4 months, the DAS28 curves were superimposable. No advantage of combinations of conventional synthetic DMARDs. And EULAR, in its systematic literature review, has also criticized, and there is a paper by Robert Landewey, the papers by Smolen and by Odell, and by Van Vollenhoven on the comparison of combinations of conventional synthetic DMARDs with biological agents, because there were major flaws in the study designs and analyses, and also especially in the RACAT trial, the ACR70, and that's what we look at, in methotrexate insufficient responders was only 5% compared to 16% when etanercept was used, so a highly significant difference, not for the low endpoints, but for the important endpoints. Well, if the first phase fails to attain sufficient improvement and reaching the target of low disease activity or remission, then EULAR recommends to stratify by risk. If there is low risk, go to another conventional synthetic DMARD. If there is high risk, and the high risk relates to high titers of rheumatoid factor and ACPA, high disease activity, and presence of erosions or failure of 2 DMARDs before, if these unfavorable factors are present, EULAR recommends that any biologic DMARD should be added, or now a JAK inhibitor, where it is licensed, but EULAR also says that the current practice is to add a biologic DMARD. Why do we say any of the biologic DMARDs and don't specify a particular one? Well, the reason for this is the data. If we look at patients who have failed methotrexate, then we see, and that's also what this is sort of the poor man's meta-analysis, just putting not head-to-head trials next to one another. But the meta-analysis show the same. And if you look at methotrexate insufficient responders, whether you have abatacept or golimumab, an anti-TNF, or tocilizumab, anti-IL-6, or rituximab, there is 20% ACR70s all over. Same result. Meta-analysis show they are not different. But we also have data of head-to-head trials. Abatacept vis-a-vis adalimumab. Same data. Okay. I don't know what happens there in the back. Same data. Same data. And also for radiographic outcomes, Same data. Now, we've seen studies like that also for rituximab very recently, published by the Glasgow group in the Lancet, but published just this week. We showed that also TNF inhibitors, comparing certolizumab and adalimumab, have very similar efficacy. Here you can look at the CDAI curve for low disease activity or remission. The rates are superimposable. ACR 20, 50, 70 superimposable, DAS 28 superimposable. So all biologic DMARDs, whether they are of the same or of different modes of action, do the same. However, we've heard that one may not need necessarily with some agents to use combination therapy. Now, for the TNF inhibitors, we knew that for long, that a drug like adalimumab as monotherapy is not better. This is the ACR 70, but that's true also for 50 and 20, than methotrexate, and that it's only the combination that is so good. For abatacept, there are recent data that show similar. At the time of the primary endpoint, methotrexate and abatacept monotherapy are the same. But here, the combination is significantly better. For tocilizumab, it has been particularly claimed that monotherapy may be sufficient. And if you look at DAS 28 ESR, indeed monotherapy is significantly better than methotrexate. But I mentioned before that with tocilizumab, DAS 28 ESR may not be the appropriate endpoint. So let's test for ACR 20, 50, 70. Yes, numerically better, but not significantly. Only the combination is significantly better. This is early disease, methotrexate-naive patients. Maxime Dougados has shown us in the ACTRATE trial that if you have patients who have active disease despite methotrexate and randomize them to receive additional tocilizumab or switch to tocilizumab monotherapy, that the combination is significantly better. And now we have a second study from Japan, primary endpoint. Patients with methotrexate, active disease despite methotrexate, addition of methotrexate, 70% DAS 28 remission, withdrawal of methotrexate and switch to tocilizumab, only 55%, a significant difference. So even for an IL-6 inhibiting agent, it is clear that the combination is superior to the monotherapy. And when we speak of combination, we don't need to maintain 20 milligrams. 10 milligrams is sufficient, as was shown in the Concerto trial. Well, if phase 2, which is the first biologic, fails, then phase 3 comes in place, and phase 3 says change the BD-MART and replace any first BD-MART by any other BD-MART, including a second TNF inhibitor if you have failed that. Why do we say that? Despite the fact that, as we've seen, registry data show that other modes of action are better. Registry data. When we look at randomized controlled trials, and again, this is a poor man's approach, then we can clearly see that whether it's abatacept or golimumab and other anti-TNF or tocilizumab or rituximab, we are in the order of 10 to 12% ACR 70 responses. And the meta-analysis show the same. The meta-analysis do not show differences. And now comes the big surprise. In the Accelerate study, which I mentioned just before, which was published earlier this week, we took failures of one anti-TNF at 12 weeks and added as the other anti-TNF. And we found again a very similar response rate as we see with other agents. About 10% ACR 70 and about 40% ACR 20. And that despite the fact that these patients did not at all respond to the first anti-TNF, which is not always the case in the other trials. These were patients who were absolutely primary anti-TNF failures. So primary non-responders exhibit similar efficacy to a second anti-TNF as we are used to see with other BD-MARTs. I'm slowly coming to a close, and I would like to address a new series of agents that are approved, at least one, in many countries of the world, none of them in the EU, but currently considered by the European Medical Agency, and that is the JAK inhibitors. The Janus kinases play a major role for a variety of cytokines, and I would like to point out the interferons, I would like to point out IL-6, IL-12, 23 also, and IL-2 also, but I'm not sure, since targeting IL-12 and 23 directly didn't have efficacy, I don't think that this is the way that the JAK inhibitors work. Probably they rather work by interfering with the interferons, and we know that IL-6 interference, IL-6 blockade is highly effective. Now, interestingly enough, again, in methotrexate insufficient responders, we see a very similar result as we saw here. Here we saw 20 to 22%. Now we see 20 and 24% for tofacitinib and baricitinib. Very similar result. However, and that needs to be taken with a caveat, it may be, because here we saw 10 to 12% in TNF inhibitor insufficient responders. Here we see 14 and 17%. It may be that these agents indeed target a different pathway than all these agents together, and therefore may have, at least that's a hint, a different superiority. I said with all caveats, we need to have more data, but there is some indication, because in one of the baricitinib trials there was a clear superiority of the JAK inhibition vis-à-vis a TNF inhibitor. Now, I mentioned that I believe that maybe interferon interference is what drives it. Do we have evidence that interferon may play a role in rheumatoid arthritis? Yes. Thomas Karanic in my group has shown very recently that in patients with rheumatoid arthritis in the monocytes, but also in lymphocytes, activated phosphorylated STAT1 is highly upregulated compared with healthy control, and that the level in the cells of the activated STAT1, and STAT1 is a product that occurs after interferon engages its receptor and Janus kinases are activated. It's a product of the Janus kinases, and so there is a significant correlation also with disease activity. So, Mr. Chairman, colleagues, the pathways to rheumatoid arthritis are complex and provide many nodes for therapeutic interventions. Conventional synthetic DMARDs plus glucocorticoids are the initial treatment of choice in rheumatoid arthritis, and this approach is at least as good as biological DMARDs plus methotrexate. If this treatment fails to attain remission or low disease activity, then further steps should be as consequence of stratification by risk factors, and disease activity assessment by CDAI is preferable, since DAS28 exaggerates response when IL-6 or JAK inhibitors are used. All biologics and the JAK inhibitors have similar efficacy. More safety information on BDMARDs is available than on JAK inhibitors. Monotherapy of biologicals is not as efficacious as combination therapy. If biologics fail, any other BDMARD or JAK inhibitors can be used, and disease activity assessment and therapeutic guidance should be solely driven by the clinical evaluation, and sonography be abandoned for follow-up, but importantly be used for differential diagnostic and diagnostic approaches. With that, I would like to acknowledge the people whose data I've been showing here, especially the task force members, and thank you very much for your kind attention.